I also put together a nice case based on a couple of different patients I've seen over the years that I put together, a couple of different pediatric patients. And what I'm thinking is we'll go through the presentation first, and then maybe do the other case that was submitted. And then if we have time, we can come back to the headache case that I put together. So we all see headaches. They're very common. About half of the adult population at any given time will have had a headache in the last month or so. At least 2/3 of adults have headaches in their life. 1/3 of those with acute headache have, 1/3 to 1/2 have tension headaches, 10% have migraines, and about 4 to 5%, so 2 to 4% of the population have chronic daily headaches. And chronic daily headaches cause a whole lot of problems affecting people's livelihood. They're also common in children, and we'll talk about that a little bit more as well. Most people with headaches have episodic headaches. So again, 4 to 5% of adults have chronic daily headaches. Chronic daily headaches are the cause of most of the referral to national headache clinics. And there's often a preceding history of migraines in people with chronic daily headaches. And the other thing is that I want to make sure everybody knows about, if you don't already, is that medication-induced daily headaches is really an unrecognized epidemic. So a lot of people with chronic headaches wind up taking medications, and then they get rebound headaches, which are causing their problem to actually be a lot worse. So the definition of chronic daily headaches is headaches occurring on 15 or more days per month for the last 3 months. They can be of short duration or long duration, and this can be helpful in distinguishing the type of headache. And about half of people with chronic daily headaches have medication overuse. They can be defined as primary headaches or secondary headaches. Secondary headaches would be those that have an underlying cause. In children, risk factors for headaches include having a family member, especially a parent with headaches, stress, vision problems, school challenges, and in children, headaches significantly negatively impact quality of life. And about half of children will have headaches at some point during their childhood. So primary headaches are recurrent benign headaches caused by no underlying disease or structural problem. Secondary headaches are caused by an underlying disease, infection, head injury, vascular disorders, etc. So what about evaluation of people with daily headaches? Everybody requires a careful evaluation. What we want to do right with our evaluation is rule out any intracranial pathology. Most headaches will not have any, but it's important when you're evaluating your patients to make sure that they don't have that. So if they have neck stiffness, unable to bend their neck, you might think about meningitis, for example. There's age cutoffs, and if you look at the literature, it's kind of arbitrary. Some say 40, some say 50. And I've had people present with new onset migraines in their 50s who I didn't get a imaging study on. But this is kind of the things that you might think about where you want to do some more evaluation if they're presenting with their first headache over the age of 50. Or if there's increasing headache frequency or progressive symptoms. And again, on the increasing headache frequency, I mean, if there's a reason for that, a 55-year-old who has chronic headaches just lost their job and they're having difficulty paying their bills, that means I might not necessarily run to get an MRI, especially if they lost their insurance. I'm looking at, do they really need to have a CT scan or an MRI? Or is there a reason for what's going on? And headache awakening people from sleep also, I see this a lot in people with migraines. They'll come in and they'll say, it is waking me from sleep. It hasn't done that before. And again, it doesn't necessarily mean that there's something new going on. So types of secondary headaches, those associated with vascular disorders, AVM, carotid dissection. I actually have a patient who has a who has a pretty large AVM, and he doesn't want to do anything about it. And it's a really tough situation because if he doesn't do something, it's probably going to bleed eventually. And he's just afraid to go talk to a neurosurgeon. So we're trying to work through that. And then headaches associated with non-vascular problems like a tumor, for example, or infection. There are a number of other issues that we see often in primary care, like myofascial pain syndrome, cervical spine disorders. TMJ is a very frequent cause of headache in a primary care practice. And then headaches associated with sleep disorders like obstructive sleep apnea. So often people will come in and they will want you to figure out what's causing their headache. I use the examination to help to reassure patients and parents that the headache is not of a severe nature that's going to cause an immediate problem, something that people are afraid, do I have a tumor, am I going to die, and this sort of thing. And what's important is doing a study, like an imaging study, like a CT scan, often does not help reassure the parent and patient. And there was actually a study on this where they looked at reassurance because what they're looking for is an answer. What's the diagnosis? And the CT comes back. We don't see anything there. There's no bleed. There's no tumor. So they're still not reassured. And so I think if you have a good relationship with the patient and you can do the exam in there and say, I'm pretty sure that this is not something to worry about, that it's a benign headache, and it's probably tension type headache or migraine, which are the two most common that you see, you can, as long as you have a good rapport with the patient and family, actually give them the reassurance that they need. Neurologic exam is crucial, and it's easy to get complacent in patients with chronic headaches. You need to really listen to your patient and know what's going on. Doing a fundoscopic exam is essential, especially with the first onset of headache or whenever there's a change in headache quality. Subtle signs of frontal lobe dysfunction can be hard to pick up on a new patient. I think when you see a patient in the emergency room with a headache, they almost always do get a CAT scan. But in primary care, if you know your patients well, you can often detect subtle signs of frontal lobe dysfunction, a change in personality, for example, that might prompt you to want to do further testing. And usually those are not present. So the other important thing is physical findings are common. So for example, if you have somebody who has neck spasm that's causing tension type headache that's leading to a secondary migraine, it's not uncommon to find physical findings. What we're looking for are neurologic symptoms, progressive symptoms that might indicate that there's a bigger problem involved. 75% of patients with migraine have neck symptoms, so that's not uncommon. Obviously, you want to rule out meningitis and this sort of thing, but don't think that any kind of neck pain means that they need an LP. And also, triptan therapy can resolve both the neck pain and the headache in patients with migraine. Sinus abnormalities are often confused with headache, and patients often have symptoms that sound like a sinus headache. And in one study, 90% of patients with frequent episodes of sinus headache actually fulfilled the criteria for migraine. So if you're thinking about your patient who is having recurrent sinus headaches, but you're not seeing signs of an infection, you might want to think about migraine. There's a whole long list, and you'll get this when we share the PowerPoint with you, a whole long list of things that can cause headache that do require further evaluation. For those folks who like mnemonics, Snoop is a good mnemonic. So you want to really look for systemic symptoms or systemic illness, neurologic signs or symptoms, recent onset or sudden onset, onset after the age of 50, and then a previous headache history that is changed. So in other words, something's different or progressive. I usually get a throbbing headache on the left side of my head, but now it's in the back of the head, and it's the worst headache of my life. Thinking about, is there a big change going on? Also, make sure you find out about their medication use. If they're using medication every day or almost every day, and especially if they're having headaches when they wake up in the morning, headaches waking up in the morning is a good sign of rebound headache. And then also, is there a sleep disturbance at night? And again, you do occasionally see that in migraine patients, but being woken up at night with a headache is not usual. Also, are there other issues going on like depression, anxiety, chemical dependency, which can also cause rebound headache, and personality disorders? So looking for these things is important. If you don't treat them, their headaches are probably not going to get better. What about imaging tests in migraine or chronic headaches? So episodic migraine does not require imaging studies. If you look at the literature for what about chronic migraine and chronic non-migraine headaches, so headaches that are occurring daily, more than 15 days a month, the evidence is really unclear about that. And again, in the absence of focal signs or other reasons to do a imaging study, it's probably not really indicated to do a CAT scan. I have had many examples of the exception to that rule where we wind up doing a CAT scan for reassurance for the patient. But in most cases, if there aren't any red flags, we don't need to do that. What about the pediatric headache evaluation? Even more important than the adult evaluation, family history, social history, and school history are really important components. And again, imaging is not routinely done for pediatric patients. Evaluating for comorbidities is very important. And sometimes the younger patients present a little differently. For example, cyclical vomiting or other atypical symptoms might be common in children with headaches, and that doesn't necessarily mean that you need to do further diagnostic tests. So at least 1/4 of school children experience headaches. It was a lot higher than I realized. Obviously, LP, if you're thinking about meningitis or encephalitis, and EEGs are unlikely to help or determine an etiology. There was actually one study where they looked at, in the absence of an abnormal neurologic exam, how many CAT scans would you need to do to discover one brain tumor, and it was 50,000. So highly unlikely if you have a normal neurologic examination that an imaging study will help there. So there's many different classification systems. One that's helpful is looking at duration. So when your chronic daily headaches are lasting less than 4 hours and they're strictly unilateral, it's more likely that they might be cluster headaches or paroxysmal hemicrania. In those, when they're unilateral or bilateral with no autonomic features, this is the differential here: trigeminal neuralgia, idiopathic stabbing headache, cough headache, benign exertional, and then headaches associated with sexual activity. So looking at those that are less than 4 hours, cluster headache, commonly misdiagnosed as migraine. They're not that common in children. You tend to see them more in adults. They're usually daily or near daily headaches when they occur, and they often occur at the same time of the year. So patients might get them in the springtime, for example, and they'll get them for a week in a row or 2 weeks or even 2 or 3 months where they're getting daily or near daily headaches. They're usually excruciating, and they're almost always associating with tearing or rhinitis and other facial autonomic symptoms, and always on the same side of the head. And the first time I had somebody with this, and I tried them on oxygen, I happened to be in an office that had oxygen that we used in patients with pulmonary problems, and they got better. We both thought it was a miracle. It was really cool because oxygen is one of those things that can give you an immediate cessation of cluster headaches. What about headaches lasting longer than 4 hours? So And this is with or without medication overuse. There's chronic or transformed migraine, and they're transformed from tension type. So tension type headaches can lead to migraine. You can also have tension type headaches, the hemicrania again, and also new daily persistent headaches that don't meet the criteria for either migraine or tension type. Drug rebound, I think we've all heard about this, but it's actually a lot more common than you realize. And it is treatable. It's a treatable cause of migraine headaches. And these patients are usually refractory to the standard prophylactic interventions as well as the standard acute treatment. So you'll have patients that are getting really daily headaches. They're trying to take medication. They're not getting better. Their headaches seem to occur every day. And early in my career, I would say in the early 90s, I had a patient who was having frequent headaches, and she had started off with maybe once or twice a month, and she was taking something like Vicodin, and then they started happening once or twice a week, and before I knew it, over a 6-month period, she was taking about 90 Vicodin a month to try to control her headaches. And we essentially had to get a specialist to help out, and that was before I really understood about rebound headache and narcotic addiction and those sort of things. And we had to stop all of her medications. We wound up admitting her to the hospital and then getting her on a prophylactic medication to get her headaches under control. So when you have patients who you don't think there's an underlying cause of their headaches, that they have migraine, for example, and they're failing to respond to preventive therapy, you might want to think that they're having drug rebound headaches. So all medications, including plain old acetaminophen, have the potential to cause rebound headache. The most common are these three: narcotics, butalbital products, and combination products containing caffeine. And there's one product that contains butalbital and caffeine. So you'll find headache patients taking that drug 2 or 3 times a day, complaining of daily headaches while they're on it. So untreated psychiatric comorbidities can really worsen the prognosis. Patients are not likely to get better with their headaches unless their anxiety and depression are taken care of. And I don't know if one begets the other, which one starts, but often if you have chronic headaches, you do get depressed. And so, and if you're depressed and you develop chronic headaches, it can cause a vicious circle. There are some screening instruments, and I think we have some experts here who can tell us why screening instruments are helpful, but also how screening instruments can be misleading. And so I think, again, in a primary care practice, using a screening instrument can be a helpful thing, but it shouldn't prevent you from doing your own assessment of patients' anxiety and depression if they're having headaches. So what about treatment? Reducing headache triggers, I think having a patient with either new onset headaches or somebody who's had an increase in headaches if they have chronic headaches, really a headache diary is essential. We used to do elimination diets. Elimination diets have not been shown to help. However, if a patient can identify a specific trigger, whether it be a certain food or a certain activity, that can be really helpful in terms of preventing. And in patients with headaches, what we want to do with them is agree on some goals. And most of our patients with chronic headaches will never become headache-free. So we have to get a sort of a shared patient-centered approach that says what would be better, reducing the number of headaches as well as reducing the severity and duration of those when they occur. And if we can get them under better control, when we do use rescue medications, they'll be more likely to help. So I want to talk a little bit about non-pharmacologic treatment in children. If a child's old enough to take notes and take a journal, it's best to have them do that. And when you're doing your initial interview, the parent is usually bringing the child in. But it's important to start off your interview by having the child describe what's going on in their words. They will have a different view of what's going on and what the problems are than the parent often will. Again, the triggers can be identified in the journal. Ensure that they have a healthy lifestyle. Sometimes kids are drinking a lot of caffeine. My oldest son, who's 26 now, when he was 13, he was drinking 4 or 5 Cokes a day, and he was having headaches. And it's like, yeah, right. So having a lot of withdrawal from caffeine can certainly do that. Exercise, what's their school participation like? What's going on in school? Are they having challenges? Are they being bullied? People that are being bullied have a very high incidence of headaches. There's a lot of things that can be helpful. Acupuncture is one of them. On the next slide, I've got a few more. So we already mentioned treating comorbidities. Cognitive behavioral therapy and stress management can be really helpful, especially in children that are having challenges in school with relationships, as well as sleep issues and this sort of thing. The relaxation techniques and biofeedback are also really helpful if they're available to the patient. Self-hypnosis, and there's a reference on this slide, so when you get this, I would encourage you to pull up this particular reference. It's a really nice review article on self-hypnosis in children. It's quite long, but it gives you a real good sense of how you can do this in a primary care practice. And especially for those of us who don't have, access to somebody who can teach children self-hypnosis, it's a really effective tool, not only for headaches, but for lots of other things. For example, asthma, anxiety. So lots and lots of things. They talk a little bit about an interview in the article, and there's some links to resources for you to be able to learn how to do that and teach children that in your practice. In the slide set that you'll get, I do a review of medications for adults and children. I just want to talk about that briefly. In children, there's really not a lot of good evidence, not a lot of good randomized controlled trials on treatments for both acute headache and chronic headache. And one of the challenges is pediatric migraines tend to be shorter than adult migraines. The average is less than 2 hours. That means a lot of them are lasting even less than that. And most medications take an hour or plus to start working. I think it's important to treat them if their symptoms are debilitating or decreasing their quality of life or decreasing their functioning. Treatment doesn't always mean medications, though. And also consider the number of school days missed. So if you have a child who's doing well in school, who starts having headaches, but they're still doing well in school and they're not missing days, there may be something else going on. So I don't think you always need to jump to a medication. I have a nice little table in the slide set that you'll get that talks about the efficacy of each of these medications. Both topiramate and valproate shorten migraine headache duration and intensity. Amitriptyline, cyproheptadine, levetiracetam, and zonisamide are effective in pediatric migraine. Propranolol, which is often a first line in adults, is really lacking evidence in children. If the others don't help, propranolol is sometimes tried. Flunarizine is really effective, unfortunately not available in this country. And then nimodipine and clonidine, which are used in adults, really don't help in children, and so those should not be used in children.